All right, we're live.
Okay, good morning. It is January 26th. This is the Senate Health and Welfare Committee. We are ready to hear information from our Ledge Council on reports that we have asked for in legislation over the past year or two. So, and just a note for the committee, as we know, Senator Terenzini is not here this morning. He had a personal thing to take care of, so we'll move ahead without him, and someone will have to bring him up to date. But I'm sure he can do the work. He's great. So, Katie and Jen, I will turn it over to you, and you can direct us through the reports that we have.
Great. Well, good morning. I'm Jennifer Carvey from the Office of Legislative Counsel. And I will, Katie, do you want to share or do you want me to share my screen?
Are you able to share your screen?
I am able to share my screen. Actually, I think I even pulled it up in anticipation. So
perfect.
All right. Can you all see my screen?
Not yet. It says
there it is.
There we go.
Oh, good.
And we have the same thing on our webpage. So if you go to reports and documents, you can find this under right there, comes right up.
And the important part about that is that if you actually go to the document, you should be able to click on the links. The links should be live and take you directly to the report. If you have any issue with that, we can send you a Word version or a direct PDF. So Katie and I are just going to go through and kind of talk about the ones that, for the most part, we were responsible for drafting the underlying language that called for the report. These are reports that were either, in most cases, due to this committee and a few other cases of interest to this committee, and we've noted those. So these are the ones that came in the later part of 2020, some of them while you were still in the latter part of the 2020 session, but may have been focused on other things or might need these older reports for a little bit of context on things that came later. Katie, anything you want to add before we jump in?
This is a very small point, but in order to see the document, I've had to minimize everyone's picture. So if you need to get our attention, it might be helpful to do it verbally instead of raising a hand, because I don't think either Jen or I could see that at this point.
Sounds good.
Good point. Thank you, Katie. All right, so these are in order of when they were due. So on August 20th, 2020, you received the first progress report on the Healthcare Provider Stabilization Grant Program. And just by way of reminder, that grant program was initially a $275 million appropriation to the Agency of Human Services to provide grants to healthcare providers to make up for lost revenue or increased expenses as a result of the COVID-19 pandemic. This was $275 million in Coronavirus Relief Fund, CRF dollars. And this first report was to be looking at the distribution of the funds to date, including the provider types, the totals by provider type, and then the totals by geographic region.
I don't want to interrupt you, but I did get an email today from Nissa James at DEVA, bringing us up to date on how many providers have actually gone out of business during the epidemic, during the emergency. So Nellie has that and is going to post it on our webpage, so you'll be able to see that. It's actually it's not bad. I can't remember. I think maybe there was one provider we lost. So the stabilization program has worked nicely.
Okay, the second report on the list had to do with a CRF appropriation for housing for households experiencing homelessness. And there was 16 million in CRF funds for persons experiencing homelessness due to COVID. There was actually no report required for this particular report, but the Department for Children and Families submitted a report anyway on August 15th of this year to report on how the funds were spent. The third item on the list was a report addressing COVID-related health disparities. This had to do with subgrants to community organizations engaged with populations likely to experience adverse outcomes from COVID due to factors such as race, ethnicity, immigrant status, sexual orientation, gender identity, disability, age, and geographic location.
The next report was on meals to older Vermonters and other vulnerable populations. This again was from a CRF appropriation. In this case, the report was from the Department of Disabilities, Aging, and Independent Living, and it was regarding the adequacy of the funding and whether they needed additional CRF money. This is actually due to the Joint Fiscal Committee, not this committee, but we thought it would be of interest to this committee as well.
The next report is also a CRF appropriation report. This was for the Child Development Division. There was 12 million in CRF appropriated for Restart grants, parent-child centers, and Children's Integrated Service. And this report had to do with how the money was distributed, and that came in August 18th of last year.
The next report is the receipts, expenditures, and balances in the Health Information Technology Fund. This is now, we're not in CRF land anymore. This is an annual report requirement from the Agency of Administration.
The next report is an annual report on general assistance, and its evaluation of the program, recommendations for program changes, statistics on emergency housing vouchers. That came in on September 1st of last year.
The next report is an annual report from the Green Mountain Care Board and the Department of Financial Regulation. It's the annual bill back report. So this is a report on the amounts that were billed back to regulated entities to cover the costs of their regulation. And so by statute, the breakdown has changed a fair amount in recent years. But at this point, there is 40% that the state bears for regulation costs, and then 30% is to be borne by hospitals, 24% by insurers, and 6% by accountable care organizations. So this report gives the breakdown there and how much was actually billed back.
Jen, can I ask a question about that? This is Ruth.
Sure.
What do you mean billed back the cost of regulation? So the sort of oversight cost, administrative cost, or is this for actual services?
So this is for things like the hospital budget review and health insurance rate review, the costs that are directly related to regulation of these organizations are allowed to be, and actually required by law to be, billed back to the entities. I'm just trying to.
Okay. I can take a look at the report, but I just wanted to, thanks.
Yes. All right, the next one is the calculation and allocation of savings in the Choices for Care program. This again is an annual report requirement from the Department of Disabilities, Aging, and Independent Living. And there's a definition of savings, basically the unspent amount less a small reserve from the Choices for Care appropriation. And the spoiler on this one, because it's a very short report, there were no savings in FY20. The unspent amount was within that 1% that has to be held in reserve, so there was no allocation of savings.
The next report had to do with the capital construction and state bonding budget adjustment for the Brattleboro retreat. This required the retreat to deliver monthly reports to the Agency of Human Services regarding the financial stability of the project, and also report on the state use of the 12 level 1 beds. And there were also updates on this embedded within this to Joint Fiscal Committee.
The next report is the annual report on global commitment investments. So these are expenses for which the state was able to use global commitment funds, meaning we get a federal match or federal Medicaid match for things that otherwise would not be reimbursable by Medicaid in the absence of our global commitment to health waiver. And so we have the federal government has been restricting and requiring us to reduce the amount that we spend on global commitment investments. So this is a report on how just under $124 million was spent on global commitment investments.
Jen, just a suggestion to scroll
Yes.
down.
Oh,
a
sorry.
little bit.
I'm looking at
Yeah,
this.
I know there may be
Sorry
some,
about
there
that.
may be some folks on YouTube who don't have access
No, thank you.
Yeah, okay.
And then the next report is the second progress report, October 20th progress report on the Healthcare Provider Stabilization Grant Program. That was due
Jen,
October 1st. It came in a little late. Yes.
sorry to interrupt you. I'm just looking at the annual report on global commitment investments, and it's basically just a spreadsheet of. It's a one-page, extremely tiny font spreadsheet. So, is that what it's supposed to be, or is there supposed to be any kind of analysis, or is it literally just a list of this is what we spent on our global commitment fund?
This is, as I recall, this is what the annual report typically looks like. It's just an accounting. I'm pulling up the language right now to see if it requires anything specific, but I think it just requires an annual reporting. Provide a detailed report to the Joint Fiscal Committee that describes the investments under the terms and conditions of the Global Commitment Waiver, including the amount of the investment in the agency or departments authorized to make the investment. So I guess it depends how you read detailed report. This has all of the report that they submitted that is, as I recall, a similar format year after year is the department, a description of the investment, and then the amount of the spend for the last several state fiscal years. And I think to the extent you have questions about any of these specifically, we can certainly get that information from the Agency of Human Services.
Okay.
So
I mean,
you're interested
to the
in,
extent that I have time, I will take a look at it, but it's really just a list for 6 years of expenses and no explanation or analysis at all. So it's not an extremely helpful report in case any of them are listening.
I'm sure they are, and they can take that back. But yes, I think if you have questions on any of these, we can certainly follow up with the agency to get information, or if you would like more information on the investments generally. I know they have presented in the past on the investments because in particular because of the requirement under our latest agreement with the federal government that we phase out or phase down some of the spending in this area.
Okay, thanks.
We're now at the top of page 2 of 7. So we're cruising right along. So this is the first of 2 reports regarding employee communications at the Brattleboro retreat. This was the interim report, and it actually came to the Joint Fiscal Committee, but is obviously of interest to this committee. And it was submitted on October 1st of last year.
The next report is the annual report from the Department of Vermont Health Access on the Pharmacy Best Practices and Cost Control Program. And this is a description of the Medicaid prescription drug program, including information on cost, utilization, and the activities of the Drug Utilization Review Board.
Next is the long-term plan for justice-involved youth. This is a report on youth in custody of DCF, adjudicated or charged with a delinquent or criminal act, and required to be in a secure placement. This came in on November 1st of last year. There's also a report on expanding juvenile jurisdiction, and this was due to the Joint Legislative Oversight Committee and Joint Legislative Child Protection Committee, again, of interest to this committee perhaps, but it was an update on the status of the plan for expansion, and that also came in on November 1st of last year. And then we have a report on Child Care Financial Assistance Program adjustments. This came into the Joint Fiscal Committee, and this had to do with the costs of adjusting the sliding fee scale to correspond with minimum wage increases, and also the cost to adjust the market rate to offset increases in the child care costs due to minimum wage increases. And that came in November of last year.
Scroll up a bit. The next one is the Medicaid program eligibility and expenditures quarterly report for quarter 4. So as the name implies, this is a quarterly report requirement from the Department of Vermont Health Access, talking about the Medicaid program caseload and expenditures.
Next is an annual report, the report of the Child Fatality Review Commission. The Department of Health submitted that mid-November of last year.
Then we have the first progress report from the Green Mountain Care Board on hospital sustainability planning. This was actually due to the Health Reform Oversight Committee, and it is combined with the next report in the form of a PowerPoint presentation. That's what we provided the link to, but you'll hear more about this coming up in the next couple of months, I think, as well. And so the other piece that went into that report is the Green Mountain Care Board report on improving provider sustainability and increasing equity in reimbursement amounts. This again is the first progress report on that topic, and this is from legislation passed in this committee last year, and that as well was due to the Health Reform Oversight Committee in that PowerPoint presentation.
So the interim report went to the HROC. The question I have is, I'm trying to remember when the final report is due for hospital sustainability planning, and then for the equitable reimbursement. Is it fall? Is it a fall report?
Well, there's different pieces. So one of them, I'm just pulling up the language right now so that I can give you the correct dates. So for the hospital sustainability planning, there was this report due in November, and then another report due April 1st with an update. And then September 1st is the final report with the final recommendations for increasing hospital financial sustainability. But they have a potential to push that out till not later than November 15th if they're unable to meet that deadline because of COVID issues. And then the provider sustainability and reimbursements, you should get the in March. So this was the progress report, and then in March you will get the final report, because it's a final report on the options that the board has identified as demonstrating the greatest potential for improving provider sustainability and increasing equity and reimbursement amounts, and then also identify those parts that would require further study prior to implementation. So you are getting the final report on this, but it doesn't do it. It identifies the most promising options.
Thank you.
Sure.
And what is you called it HROC, Jenny?
Oh, sorry. Yeah, we spelled out here. It's the Health Reform Oversight Committee. It's
is
an
it a
interim
legislative committee?
Yes.
Okay.
It's a joint legislative committee, House and Senate, and last biennium it met only during the second year. I chaired that committee, and so now it'll shift over to be a House member chairing it. So we'll see what happens.
Got it. Okay.
All right. Then next up, we have the prescription drug cost transparency report. This is one that has to come be submitted each year by the Office of the Attorney General. And for those of you who are familiar with this, this is part of this is the requirement that the Department of Vermont Health Access and the two major insurers provide lists of 10 drugs each on which they spend the most money, and for which, or spend a lot of money, and for which the wholesale acquisition cost has either gone up 50% or more over 5 years or 15% or more over the last year. And then in the legislation, the Attorney General's office is supposed to go to the manufacturers and get information from them. I know there have been some challenges in implementing this provision, and may require some further legislative attention at some point. The next section, the next report on the list here is coverage for healthcare services delivered by telephone. Some people are calling the audio only telephone report. This is based on a requirement from the COVID legislation last year that, well, not requirement, it was a permission for the Department of Financial Regulation to adopt emergency rules that would, among other things, require health insurance to cover services delivered by telephone. And this was to look at what the status should be of insurance and Medicaid coverage for services delivered by telephone after the end of the COVID-19 state of emergency. So this is a report from the Department of Financial Regulation with the working group that they convened recommendations. And that came in December. And then we have a quarterly report on long-term care Medicaid, specifically the Choices for Care program. And this was, this looks at the budgeted amounts versus actual amounts spent. And in this particular case, it did come in under budget, which may be related to the state of emergency.
The next report at the top of page 3 has to do with the status of the fiscal year 21 appropriation for Woodside. And this included the cost of partial year operation and also payments to third-party contractors. This came in on mid-December, December 15th of last year.
Next, and I think this is the first one on our list that it does not have a live link. This is the annual report of the Emergency Medical Services Advisory Committee. And I checked most recently this morning. There does not seem to be, at least on our website, a report. Didn't find one for 2020 either, so I'm not sure if they are planning to submit this report or not, but it was due on January 1st.
Who's responsible for submitting that?
The Emergency Medical Services Advisory Committee.
Do we know who the chair of that is or who supports it administratively?
I do not. I can look into that. It is something that I have not personally worked on. I don't think Katie has either. I think this may have been something that was done in the government operations committees.
Right. Well,
but
so, you know, look at, as we look at S42, I think it is, the council, the mental health bill for emergency medical service folks, maybe we can sort that out a little bit.
So it does look like it is established by the Commissioner of Health, but I don't know what, so that's a requirement in statute that the commissioner established this committee, advisory committee, but it does not actually include, oh no, it does include the commissioner designee. So there is somebody, should be somebody from the health department who's on the advisory committee.
Well, I can sort of understand the lack of a report this year, but I think we should, if it's not something that is useful, then maybe we could consider, you know, whether in the going forward it's useful.
Mm-hmm.
The next item on the list are in a similar position. It's the Marijuana for Symptom Relief annual report from the Marijuana for Symptom Relief Oversight Committee. That was due January 1st. That has yet to come in at this point. And that's followed by another substance use disorder report, or another substance report. This is the report on the Substance Misuse Advisory Council, and they're reporting on the goals of prevention programming and also the result of the program evaluations. This is an annual report that comes in on January 1st. And if you remember, this was a fairly new requirement because this Substance Misuse Advisory Council was only created, I want to say, two to 3 years ago.
And I did just go through, back to the EMS one for a moment. I did just go through, I think they may have combined last year's report with some other things from the EMS advisory committee into one big report. So I don't want to get them in trouble by saying they did not submit last year's report. I think maybe they did. It was just combined with something else and so had a different type of name. But we still don't have one this year.
Right. So we should, I mean, it would be helpful probably for whoever is preparing the report to let us know whether the best way for them to provide that information and whether or not this annual report is needed. So, okay, thanks.
All right, sure. The next is the Office of the Healthcare Advocate annual report. So this is Mike Fisher and his team over at the Office of the Healthcare Advocate, which is affiliated with Vermont Legal Aid. This is an annual report requirement by January 1st.
The next report is a report of the Advisory Council on Child Poverty and Strengthening Families. A spoiler alert is that this one, the council was only able to meet one time last summer due to the longer legislative session to address COVID. So there are no recommendations in this report. It's more of a placeholder than anything else. Next is the report of the Mental Health Crisis Commission. And this, you know, the date here is January 1st, 2021, but I think they have the flexibility to submit this report anytime within a particular calendar year. So it could be that last year they submitted it on January 1st of 2020, and it hasn't come in yet for this year. The next report is the integration of social services. This has to do with a plan to coordinate financing and delivery of Medicaid, mental health, and home and community-based services with all-payer financial target services. This is due January 1st of 2021, and you've already received that. And next is a one-time inventory of substance misuse programs. This is to look at the program cost, geographic reach of each program, and gaps in services. And this is submitted by the manager for substance misuse programming, who also staffs the Substance Misuse Advisory Council, who submitted another report on this page. So that report came in on January 1st of this year.
Next, we have notice of introduction of new high-cost prescription drugs. This actually doesn't come into the legislature. It's required to be posted on the Attorney General's website. And so I've included a link here that just takes you to the listing. This is a requirement that manufacturers notify the Office of the Attorney General when they are introducing a new prescription drug to the market that has a wholesale acquisition cost above the threshold for a drug to be considered a specialty drug under the Medicare Part D program. So it's just a benchmark to use to let manufacturers know when they need to notify the Attorney General's office. So this is the Attorney General has to update this at least quarterly, and there's a whole list of them if you want to go look. Next.
Oh, go ahead. I thought it was mine, but you take it.
Okay. Next is a requirement for the Green Mountain Care Board to post on its website the impact of prescription drug costs on health insurance premiums. It's supposed to be posted on their website annually by January 1st, although I believe I've seen somewhere else that they this I think is in progress, but is not available yet.
Okay, I see. You added a new row, and now I'm on the right track. My hard copy didn't match what was on the screen. So next is an inventory of Agency of Human Services grants. And this list, this inventory contains the title of the grant, the date, the summary of the grant, the responsible department, the expiration of the grant, and that comes in every year. So that's a January 15th report. After that is an annual report from the Commission on Alzheimer's disease and related disorders.
The next is the annual report from the Human Services Board. It was due by January 15th, but has not come in yet. This is a report on the things like the numbers of fair hearings. The Human Services Board hears appeals from applicants, beneficiaries, and licensees of the Department for Children and Families, Department of Vermont Health Access, and Department of Disabilities, Aging, and Independent Living. So they're supposed to provide some information on what kinds of appeals they received and how those turned out.
The next report is also an annual report of the Maternal Mortality Review Panel. That brings us to the top of page 4. There is a report on lead poisoning prevention in young children. This is an annual report, and it contains aggregated lead screening information and testing information.
The next report is actually...
I'm going to interrupt, but I'm sorry. You know, as I'm looking at some of these reports, I guess it would be asking the committee and also Katie and Jen, there may be some of these reports that frankly, we don't need anymore, or that could be integrated into other reports and then the data, specific data be referenced. So in looking at lead poisoning, which is really important, it may be that the information is integrated into another Department of Health report, and then the data that supports it is on a web page somewhere in the Department of Health. So those are the kinds of questions maybe we can ask about some of these annual reports. I'm not targeting this one specifically, but as we go through, just think about that, please. And we'll, as we talk with the administration, maybe we can reduce some of the reporting requirements that we're seeing. Sorry about the interruption. Go
Not a
ahead.
problem. So the next one is not actually a report that is due yet, but I left it in here just to as a placeholder for this idea in your mind. So this is a report on the operation of the wholesale prescription drug importation program. This report would presumably be annual once it's operational, once this program is operational, but you may want to get an update from Ina Backus or others at the Agency of Human Services on where this program stands. I know they had submitted an application to the federal government for the program, and things had been looking like the regulations that had not been in place for a long time may be getting developed. So it might be good to get an update on that.
The next report is an annual report from the Department of Mental Health on the extent to which individuals with a mental health condition or psychiatric disability receive care in the most integrated and least restrictive setting available, including specifically the report addresses adequacy of capacity at each level of care, individual experience of care, performance of the state's mental health system of care. And after that, there is a report from Dale on the implementation of the plan for developmental disability services. This is the implementation of the system of care plan, and it also addresses unmet needs. And this is also an annual report.
Next, we have the annual report from the Vermont Information Technology Leaders, VITAL. They're the ones who are responsible, among other things, for the health information exchange. Then we have the Green Mountain Care Board annual report, which has come in and is available to read. And I think you had maybe talked about making sure people being interested in reading that one. Next, we have the healthcare expenditure analysis. This is available. So the link here goes actually to the Green Mountain Care Board's website. They posted it in July of 2020. It's an annual report by January 15th, but I think that the timing for when they had the update ready was in July. So that's available on their website.
Next is an annual report from the Deaf, Hard of Hearing, Deaf Blind Advisory Council, and that came in on January 15th.
And we have the annual report from the Clinical Utilization Review Board. So they give an overview of their the topics that the board reviewed in 2020. This is part of the Department of Vermont Health Access. So they provide guidance and recommendations to the commissioner of DVHA on coverage in the Medicaid program. They're also directed to report their success in improving clinical and utilization results in the program.
Next is an annual report from DCF on the distribution and use of supplemental childcare grants. These are the grants for extraordinary financial relief to assist programs that are at risk of closure.
Then we have the report of the Vulnerable Adult Fatality Review Team. They examine annually select cases of abuse, neglect, and neglect-related deaths and preventable deaths of vulnerable Vermonters. Following that is the annual report from the State Long-Term Care Ombudsman on complaints, conditions, and quality of care in Vermont's long-term care facilities.
The last two reports on the page are sister reports. They're both on the same topic, the administration of involuntary non-emergency psychiatric medications. And they're both annual, but they're required to be submitted by two different entities. So the first one is submitted by DMH, and the second one is submitted by an independent evaluator.
Can I just ask a question, Senator Lyons? Who is the long-term care ombudsman?
Well, literally the State Long-Term Care Ombudsman's name is Sean Lonergan, but the State Long-Term Care Ombudsman project is also through a contract with Vermont Legal Aid, like the Office of the Healthcare Advocate, although they're separate programs within Vermont Legal Aid, but both of them are contractual relationships and required by statute.
Thank you.
And FYI, Sean Lonergan will be coming into our committee. I think it's Thursday, so you'll be able to hear about that office.
Okay, thank you. I had a constituent call about that yesterday, so I'm anxious to hear some information.
Good.
Yes, and I'm happy to give you his contact information if you want to be in touch before then.
Okay, that'll be great. Thanks.
Can I ask a quick question to back on the report about the distribution and use of supplemental childcare grants? Is that CRF funding or is that a different funding
No,
stream?
that's ongoing. This is in statute. So this is an annual report, but it's a program in statute. It's ongoing and it's not just in response to COVID.
And it's grants to actual programs, not individual families. Is that correct?
Correct. It's grants to programs that are at risk of closure.
Okay, thank you.
And hopefully we'll be able to do something that closes the gaps in the system so we don't see the closures. Anyway.
And the next report is also annual, but it's part of the budget presentation. This is the Homelessness Emergency Shelter Grants and Management. AHS is to develop a baseline to measure the results of investment in emergency shelter grants and case management services. Next is the Substance Abuse Treatment Services Delivery Program Success. This is an annual report from AHS, the Department of Health, and DEVA. And this looks at the success of service delivery system and reaching the program's objectives.
The next is the first of a few different time-limited annual reports. So this one is Payment and Delivery System Reform for Medicaid Services and Providers, what's sometimes called Medicaid Pathways. And this is looking at payment and delivery system reform as part of an integrated system of care across the care continuum. It's an annual report from the Agency of Human Services, and it is annual between 2017 and 2022. So we're coming close to the end of that report requirement.
The next report is also an annual report. It was a report that was coming in for 3 consecutive years, and this is the last report. Data on patients seeking mental health care in hospital settings. This included data submitted included the number of individuals seeking psychiatric care, both voluntarily, and the number of individuals in the custody or temporary custody of the commissioner who are admitted to inpatient psychiatric units, and the corresponding length of stay for each of those categories.
So I think some could see this as an ongoing problem, and we probably as a committee want to discuss whether or not a similar report should continue going forward, and knowing, of course, that COVID has had an effect on our mental health in emergency and other parts of the hospital. So just a heads up on that one.
The next report is also an annual report, time limited, so we're kind of right in the middle of the reporting period. It's an update on progress in addressing CMS requirements to reduce federal Medicaid spending, on IMDs, institutions of mental disease. That's a federal term, that's not our term. And this has to do with the impact of the requirement to reduce and terminate federal IMD spending and the number of existing psychiatric and substance use disorder beds that are at risk, and the state's plan to address the Vermont's bed needs and the potential of attaining a waiver from the federal government.
Next is a one-time report on the use of funds appropriated for emergency medical and ambulance services. There was funding appropriated in what had been the Q1 budget bill last year for emergency medical service and paramedic training, and also for stabilization grants. And so this is a report on how that money was spent.
Next is an annual report on the evaluation of pre-K programs. This report is a joint report between the Agency of Education and DCF to monitor and evaluate pre-K programming, including programmatic details, quality, and student school readiness for kindergarten.
Then we have a report that has not come in yet, but was supposed to come in by January 15th from the Department of Financial Regulation, one-time report on their enforcement of 24 VSA section 2689A. This is an existing requirement that health insurers reimburse ambulance providers directly for providing ambulance services. but there had been some concern about the level of enforcement. And so a bill from last year directed DFR to report back on their enforcement of this provision.
Katie, actually, does anyone have questions about that one? I want to go back to the pre-K. Did you say that that report is not or is in, and it's not in our committee, but
I guess
do you
we
know where it
haven't
is?
seen it yet. If it's not hyperlinked,
Okay,
it
so
is
we
an
just
annual
have-
report. The fact that it says 2021 makes me think it might not have a firm due date on it, but I'd have to go back and look at the statute to confirm that. So it might be that it's just an annual report with no specified date
Okay,
on which it's supposed to come in.
thank you.
That's right.
Okay, good.
So the last report on this page is the plan for youth with mental health disorders and recommendations for repurposing Woodside. This came in on January 15th, and it's a plan to provide comprehensive mental health services to youth, including justice-involved youth.
Okay, we're getting close to the end. We're on page 6 of 7. The next is the final report on the Healthcare Provider Stabilization Grant Program. So this is how the grant money was distributed, the amounts to each provider, and this is again from that large CRF appropriation to the Agency of Human Services, and that report did come in. Next is something that this committee, I believe, worked on as well last year. This is a report that was due, has not been submitted yet, from the Vermont Program for Quality in Healthcare, VPQHC, on an evaluation of the COVID response telehealth connectivity program. $800,000 was appropriated for equitable access to telehealth by providing outreach, education, and equipment, and VPQHC was directed to evaluate the effectiveness of the program.
So I should say that I have received a communication from VPQHC about this. I'll circle back and remind myself what was in that email. And if anyone on YouTube who has submitted information about this, would be helpful to send that to Nellie. I think we should look at that at some point. So. And as I said, I did get an email, and I'll go back and see how much information was in that email.
The next report is the final report on the mental health from the Mental Health Integration Council. And that report is to identify obstacles to full integration of mental health into a holistic healthcare system. And now that I'm reading it out loud, I'm almost certain that they asked for an extension on that. So I do not believe it's due on January 15th, and we will update the document with the new due date. The next report is embedding mental health clinicians in police barracks and the implementation status. This was a report due by the Department of Public Safety in partnership with the designated agencies. And the report is on the implementation status of expanding capacity of embedding mental health clinicians in the barracks.
So what I'm hearing from community members is that it will be important for committees like ours, mental health jurisdiction, to take a look at that program and perhaps make recommendations for improvement. It's a new program, and obviously there'll be changes that should be made. So we will, I think at some point we'll take that up.
Okay, next we have the Adult Protective Services Program Annual Report. This is based on legislation enacted last year as part of the Older Vermonters Act. And this requires the Department of Disabilities, Aging, and Independent Living to provide a lot of data on their adult protective services activities, including the numbers of reports of abuse, neglect, or exploitation of a vulnerable adult, the types of maltreatment, the timeliness of investigations, and information on substantiations of reports and appeals. Next, and we have now crossed the line over to things that are not due quite yet. So to the extent these haven't come in, they're not officially due yet. This next one here is the Blueprint for Health Annual Report. So this is supposed to include information on their efforts regarding patient-centered medical homes, the hub and spoke program, community health teams, and care management activities. And this is due annually by the end of this month.
The next report has to do with the Reach Out program. It's an evaluation and comes in annually, and it's the progress in achieving the program goals from DCF. The next report is from DIVA. It's due on February 1st, and you'll again see it's time limited 2020 through 2022. But it's on the prior authorization for MAT and Medicaid. And specifically, the report is to address which medications require prior authorization, how many prior authorization requests have been received, how many have been approved, and the average longest lengths of time for DIVA to process a request. The next report is patient experience and quality of care at the retreat. This is coming in from DMH on February 1st. And the next report after that is the final report on improving communication and relations with Brattleboro Retreat employees. If you remember, you received the interim report in October. The final report is due February 1st, and it's to describe steps that the retreat has taken to improve communication with employees and an assessment of the effectiveness.
Right, and then we have, I think all the rest of these are me, so Katie can relax. The next is a progress report from the Green Mountain Care Board on the development and implementation of their price transparency dashboard. This is the interactive online price transparency tool that they are to be developing, and it's supposed to be ready by next February. And this report in particular was supposed to also include the board's efforts to validate the information in the VCures system, Vermont's all-payer claims database, including using hospital discharge data to determine the accuracy of the VCures data. So that is due by February 1st. Then there's a sort of a closeout report on CRF from the Agency of Administration. This is a report due by February 15th on all grant programs administered through December 30th, 2020 using CRF funding. So I don't believe that's specific to this committee, but to everyone. Next, we have one of the first of two reports based on last year's bill on increasing primary care providers and nurses, so workforce. The first is a report due by March 1st from the Agency of Human Services that would identify state sources of the state match for the primary care physician scholarship program that was created last year. So last year it was obviously had a one-year appropriation and was funded with global commitment investment dollars. So we received federal match on that. And language added by the Senate Appropriations Committee requires the Agency of Human Services to come back with a recommendation on where the state match should come from for this year. And I think going forward as well.
Yes, just as a reminder, our committee recommended that some of the funds identified for loan repayment or scholarship payment go for primary care. The concern in the Appropriations Committee was it not become operationalized over time. So we're having a report come back about where does the money come from. There were other workforce initiatives that were seen as critical, as well as primary care docs, so and others. So we'll just pick this up at some point, see what we need to do.
Right, and just by way of reminder, this primary care physician scholarship program sunsets in 2022 if the legislature doesn't take action. So some of that is to require check back to see where this state match might come from and whether this is a program you want to make permanent. The next report also from that same act, this one is on Vermont's nursing workforce shortage and the primary causes and proposed solutions. So this one is specifically from the Director of Healthcare Reform in the Agency of Human Services. It is also due on March 1st. And this again was an addition from the Senate Appropriations Committee last year. Then we have the,
And I just to go to that one again, there's been such a concern, ongoing concern about workforce in the state, nursing being on at the top of the list, I would think. So this is another report. Even though the Rural Task Force provided some recommendations on increasing nurses and the kind of the solutions for us, we will see a bill in committee on the nurse compact, again, interstate nurse compact. That should be coming in within the next couple of days. So I think it will come here, and we can perhaps move that one along. So this is going to be an ongoing question. What are the solutions for workforce?
all right, the next two reports I kind of foreshadowed earlier, but the first is the final report on provider sustainability and equity and reimbursement amounts. This is the report due by March 15th from the Green Mountain Care Board with identification of the most promising options. And then a couple of weeks after that, April 1st, is the board's second progress report on hospital sustainability planning with their progress in considering and developing recommendations to increase hospital sustainability. Then by April 15th, you're expecting a report from the Agency of Education and the Department of Health on their ongoing efforts to support schools and school districts in providing comprehensive health education. And this one was specific to include sexual health and safety. This is the one that came from the bill last year on increasing access to contraceptives. And then finally, we have the report due by May 1st from the Secretary of Administration on the proposed process for developing the Vermont Action Plan for Aging Well. And this again came from last year's Older Vermonters Act.
Could I jump into, are you, sorry, Jen, were you done?
I'm done.
I wanted
Yes,
to just
I'm done.
follow up on the Mental Health Integration Council. I was looking at that while Jen was finishing up. So we had that the date due was January 15th, 2021. The council's first meeting was scheduled to be in October 2020, but the legislation, a subsequently enacted piece of legislation bumped the first meeting of the council back to January 15th, 2021. So they have only begun meeting January 15th of this year and therefore do not have a report to submit.
Katie, I'm sorry. Which one was that? I didn't catch when you were.
It's on page 6, the Mental Health Integration Council.
Okay.
Yes, I tried
great,
to
thank you.
highlight it in gray on the screen.
Yeah.
Yeah.
So what
and so-
happened was that they were supposed to begin meeting earlier, but you passed a piece of legislation that would push out the date of when they would begin meeting so that they would not have a report due on January 15th, as it's the first day that they were authorized to meet.
And they also, DMH also sent a letter to chairs of committees asking if it would be okay to defer reporting because of the timing issue. So, and I think we all said yes. I know I said yes. Okay, why don't we open it up for questions for Katie and Jen, and then I have a couple of questions after. I'll let you guys go first if you'd like. Senator Cummings, Senator Harvey, Senator Hooker, any questions?
Okay, I guess I just have a general question. Which is, I'm sure you've read every single one of these reports, right? There's so many reports, and I'm wondering. I agree with Senator Lyons that we should maybe look through the list and figure out or ask for recommendations for ones that aren't necessary. But I'm wondering if any of them have included, major policy recommendations that we may want to consider. And if so, and or if you have recommendations for the ones we should definitely read. I mean, I heard the Green Mountain Care Board annual report on that recommendation list, but are there others that are must reads aside from, we each have our own areas of specific interest, but and
So
yeah.
let me jump in here unless Jen, do you want to say something?
Nope, you go ahead.
So as we were going through the reports, I was sort of segregating the reports into areas and thinking that individual members of the committee might want to focus in on one or more of those areas. And and then within some of the reports, some of the annual reports that have data are interesting and useful if you scroll through them over time. But as you said, Senator Hardy, you're absolutely right. Some of these have some important recommendations that we might be able to use. So I was thinking that we could maybe throw out some areas of interest, and then folks can identify reports that they would like to go through and look at. I don't want you to spend your whole day doing this, but certainly looking at executive summaries and then looking at specific recommendations and then as we go through our legislative work and look at bills, and there might be some policy recommendations that we could make. So how does that sound? Sound like a sort of a plan, Senator Cummings? And you're muted.
Good at that. Do you have specific areas that you want the committee to be working on this year? Because the range in here is so broad that it might help if we could focus on getting information on things we're going to be working on.
Well, we're going to be working on a lot of the areas that are here. And obviously one area that we will definitely be working on, and I know it's included in the governor's budget, is childcare. That's going to be a heavy lift for us. And I think we need to follow through with some of the mental health work that's going on, and included in that, the prevention work that we haven't heard about recently. Then there are some other things that are happening that in the healthcare reform world, and we'll hear some of those things from Ina Backus tomorrow. So, as we go forward, I think that some of these reports will become important to us. I'm not interested in having everyone go out and read the reports and come back in and say, we have to, work on this one. Rather, give you an area of interest, and then as we get to those areas, have you be our resident expert on some of those reports. It's not going to be easy, Senator Cummings, because so much of what we're going to do touches on a lot of what we're seeing here, whether it's global commitment.
Now, I just,
so on.
Because I chair another committee that also has a lot of reports,
Has a lot here.
I'm trying to be selective and also protect my mental health.
Oh, good. We all
That's
need
a good
that.
segue.
That's a good segue. Jen and Katie, do you have any specific suggestions? No. Okay.
No, I mean, I mentioned the Green Mountain Care Board report mainly because a lot of things get loaded onto that report either as a one-time or as additional report requirements. And so I think it may give you a fair amount of information about what the board does, and then also the deeper dives that they've done on certain things at your request.
Exactly. And, so I think some of this review of reports is educational. If you haven't been deeply embedded in the committee work, so it will be helpful. Senator Cummings.
I gotta watch my quarter inch and I lose my audio. It might be helpful with some of the annual reports, the child mortality and lead poisoning, if those just got reported, if there was a change. Because, if every year the report is we've got 10 kids, then, and we haven't decided we're going to do anything, then maybe we don't get they don't need to write that to us every year. Some year we're getting 15, or it starts going from 10 to 12 to 18, then you've got a new trend and you might want to know that.
So at least with the fatality review team ones, they typically take a few cases and really look at what happened and what went wrong, and if there are recommendations for changes to the system to try to prevent similar incidents in the future, things like that. So those, at least in my experience, are not numerical data,
Right.
but more, much more of a narrative and an analysis of the system.
You're talking about the maternal mortality review.
Maternal
panel,
mortality, child fatality, vulnerable
Right.
adult fatality. We have
Right.
separate teams and panels looking at all of those.
So here's what we should do, because I agree with Senator Cummings that there's some of these reports that they're extremely valuable, but are they informative for us during the session? And so that's a question we want to think about. Senator Hooker, I think you had a question.
Just going back
Comment.
to Senator Hardy's question about policy recommendations, and is there a way of teasing out the policy recommendations in all of these, each of these reports, so that we can look at them and see if these are things that, you know, we need to act on this year? So I don't know. I mean, I don't want to put more work on legislative council, but is that where, you know, how would that happen?
So here's my thinking on that one. And this was going to be my recommendation, to go through kind of the list of topic areas and allow for each of you to pick one of these areas, and then very briefly look at executive summary and recommendations. But I think it is our job to do that. Katie and Jen can certainly help us with that, but I think in terms of what you feel is important to bring to the committee, I think is also critical. So let me just share with you some of my categories that I had. So I had housing, homelessness, healthcare advocate, possibly reach up type reports together. Then I have child care, parent-child centers, a prevention council, pre-K in a group. Then I have older Vermonters, choices for care, Alzheimer's, long-term care, adult protective services, those in a group. And then I have a large group with the Green Mountain Care Board, and I think that report would be informative for each of us to read. But then sort of the mental health, the provider stabilization, global commitment, those things as another cohort. And then I thought all of us might look at substance use disorder prevention, hub and spoke, some of that. So what do you think about that kind? I know it's not clean, and not every report falls into each of those categories, but at least it would give each of you a direction for something to look at and to consider. And then we would have you would have an opportunity to identify those policy recommendations that we can act on in committee. Katie and Jen, do you want to improve my categories? Okay. Please, no. Okay. What does that sound like to you? I'm looking at the committee here. What are your thoughts there? Go ahead.
Thanks. I think it sounds good that we divvy things up. I look at the reports and I want to read a lot of them, but I know that I won't be able to find the time to do it. So to be able to rely on each other to say, oh, I read that report and this is what I found or whatever would be great. And I'm happy to do all the childcare and early childhood kind of reports unless somebody else wants to do it, but that's an area that has been one of my big concerns. And I also am really interested in reading the sort of broader healthcare reform reports. And I'm happy to do those, although that Green Mountain Care Board sort of fits under that report fits under that topic. But, I'm tempted to say I'll do the long-term care and elderly ones too, because that's an area I'm really interested in, but I'll stop with just those broader healthcare reform and early childhood type reports.
So what I would suggest is you take either childcare and I was gonna put myself in the position of the healthcare reform,
Okay.
given my experience with that one. And then everyone can look at Green Mountain Care Board and looking at some of these reports is extremely educational and informative. So it doesn't mean you're limited to the area, but it means that you're really taking some time to identify, as Senator Hooker has said, the recommendations and hold on to those for us so we can bring them into discussion, because we'll have a chance for that discussion in committee. So Ruth, unless someone else wants the childcare group.
And I can also include in that the sort of maternal health type stuff.
Yeah.
And
Yeah.
anything that has to do with babies and children and moms.
Okay, now you've just extended yourself across the spectrum, but
well,
no.
there are only a few of those, like the maternal death report, which is really short. I just looked at it.
Yeah,
One
no,
woman
do that.
died last year in childbirth in
Oh.
the state, apparently.
Well, so and then, as Senator Cummings has suggested, bring in your thoughts about whether or not these reports, or how these reports might be more useful to us, when they should come in. This is something GovOps asks us to do all the time. So this would be an area that we can help. Okay, so I'm gonna co-opt and take Green Mountain Care Board, DEVA, Brattleboro Retreat Hospital finances and those things, unless there's real pushback.
We'll all be working on that anyway.
Yeah. Yeah.
I would volunteer to take homeless housing and homelessness and aging, perhaps.
Okay, if you did that, that would leave prevention, substance use disorder for Senator Cummings and nothing for Senator Terenzini. We can split up. I think we can split up some of this work for the older Vermonters, choices for care, Alzheimer's, long-term care, adult protective services. That could be split up, I think, Senator. So what about sticking with homelessness, housing, healthcare advocate, long-term care ombudsman, something like that?
Okay.
Are you going to give us a list of what's coming under these topics?
I'm just reading off what I see as under those topics, and
okay.
That's it.
Because I've got Vital, which I've worked on.
All yours.
Oh, yeah.
It's all yours.
No link to that. I'll have to find it.
Hasn't come in yet. That's why there's no link.
Yeah, the
no
ones that
link to
haven't
it.
come
Okay,
in.
good. I like that one. I can't read it.
IT stuff that needs to be looked at.
Yeah, in the developmental isn't in yet. I can do it Alzheimer's because I've got experience working there.
Why don't you do Alzheimer's, the deaf and blind and hard of hearing, And
That was one I
perhaps,
was wondering if we needed to keep getting, but I'll read
yeah,
it.
so I think that because you've also had hearing aids in your committee, that works. We'll save some of the older Vermonters' choices for care, adult protective services. Actually, adult protective services, maybe Senator Hooker, you want to dive
Mhm.
into that? And we'll put long-term care, choices for care and older Vermonters in. We'll ask Senator Terenzini to look at that section. I know it divides it up a little bit.
Okay.
How's that?
Okay. I'm thinking Senator Terenzini might like to do the housing piece. I know he was very interested in, the housing that's going on in Rutland County. And I don't know how that, well, I'm happy to do housing because I
Yeah, this doesn't mean that
carried over from.
yeah, it doesn't mean that you can't do
development.
something else and you can't look at your own
Okay.
area of interest. I'm just trying to get the
True.
report sorted out.
There aren't that many housing reports on this list. I
No,
think
they're
there's
not.
only two.
No, they're not.
So
So-
that might not be a full category.
So that's easy enough to do. Okay. And then we'll just divide up. I'd like to do the long-term care
Okay,
choices of care type thing, just
Yeah.
because that's fresh in my mind from a correspondence that I've had with constituents. So.
sounds very good. We still have some prevention council and substance use disorder reports that perhaps Senator Terenzini can.
That would be, yeah, I think that would be good.
I think that given, yeah, that especially since he's new to the Senate, it might be helpful to have something like that.
Okay.
Okay, there's not a specific number of reports with this, but it is an area. And if you see a report that definitely relates to that area, please read it and look for recommendations. But do take some time over the next few weeks to look at those reports. So Katie and Jen, any thoughts you have? We could go through the whole list and then say, I'll read this, I'll read that. We've done that in the past, but there's so many this time. I think let's just try and stick with some areas of interest or topics. But JD and Ken, JD and Ken? Okay. That's the second or third time I've done that. Okay, Katie and Jen. Any thoughts? Okay. I do have another question for you two. Ruth, did you have a question?
Oh, I just wanted to say one of the reasons there are so many more reports this year is because of the pandemic and
yeah.
the reports that we required. So that should definitely be noted, that there are extra reports because of the federal funds, the CRF, and our pandemic situation. And we are the healthcare committee, so that makes sense.
We are the healthcare committee. And what's really interesting, I think you're absolutely right, and we're going to see more reports coming back to us as we have additional funding. But the other thing that I notice is how many other committees are also the healthcare committee. Everyone is a healthcare committee now. And that's a good thing. And it's also a bad thing. It makes it interesting to say, the very least. But it is a good thing because I think public health has resonated with folks and they get it and understand what's going on. So that's good. Katie and I almost said it again. I really apologize. There are a couple of things that I would like to have you go over with us while we're all here together and we have a few more minutes for conversation. So one is Katie on sort of talking with us a little bit about IMDs and how maybe if you can off the top, I'm not asking for a thorough formal report, but inform us about the how mental health patients are cared for in our state and what is an IMD? And why does the federal government have that designation? And how does it affect us? I know it did have a significant effect during the Woodside conversation. So can you do that very
Sure, I'm
real
trying to
briefly?
remember all the specific details
Yes,
off the top of
okay.
my head. But IMDs, it's a federal term, it's a federal designation, and basically it's language in federal law that says an institution of mental disease cannot receive a Medicaid match if a facility meets the definition of an IMD. And I'm wanting to say that means that it's larger than 16 beds, but don't
I
quote
think
me
you're
on that
right.
specific
I would
number.
agree with you.
Okay, great.
I've heard you say that a number of times.
And so historically, Vermont has gotten a waiver from the federal government to allow it to operate facilities that were larger. Even as recently as when the Vermont Psychiatric Care Hospital was being constructed, Vermont received an email assurance from the federal government that if we constructed a 25-bed facility, we would still have a waiver to be able to draw down federal funds to operate that facility that was over 16 beds. And the facility was constructed the way it was with separate units in order to be able to take one unit offline in case there was ever an issue with receiving those federal funds. So that's a very high level overview of what the IMD is. And more recently, the federal government has indicated to Vermont that we would no longer be getting a waiver from the IMD program. So any facility that was operating above the 16-bed threshold would not be eligible. And so the report that we went over today talked about Vermont's planning to move the report was looking at how many beds would be affected, how it affect Vermont's services, what would be the cost implication, is there a possibility for a waiver? And even more recently than when this report was requested, there have been indications that we might have an opportunity to negotiate to get a waiver for IMDs. So I couldn't tell you exactly where that stands right at the moment, but it strikes me as that it's still an ongoing process and conversation.
Senator Cummings.
Am I muted? No.
No.
Good. I'm just looking at things. I know there was discussion about moving the Middlesex facility to Berlin, to the old library, the property. And there was a concern that the federal government would say, well, you're a quarter mile apart, therefore you really are one facility. Since we recently announced removing the state police to Berlin, can I assume that that risk was too great? Does anyone know? And does anyone know what's happening to the Middlesex facility, temporary facility that's been there?
We can, we'll pull folks in. Maybe Katie, is there a way to get an update on that?
I know there's a proposal from the administration. I heard a colleague referencing it. So I think the institutions committees are looking at it, but I haven't heard what the specific proposal is on that yet. But Senator Cummings is right that there's the 16-bed threshold, but there are a lot of other criteria and nuances. And, there's an issue of proximity, a facility that's in close proximity with another facility. They could be looked at collectively to get to that 16-bed threshold. So I don't want it to sound as cut and dry as it's just about 16 beds in a building. It is much more nuanced than that.
It was
right. So
very controversial when we did it, because what was it 50 something was our daily population at the state hospital.
it was 54
we had been
or
trying to
57.
get that. Yeah, we've been trying to get that population down for years, and we never got it down to anywhere near 16.
Right.
And then the flood just brought it all to a head. We had to do something. But that's been a lot of the issues with Brattleboro, and it's just that.
Right. And so, and we're also, one of the critical issues today is having transition beds once folks are moved from acute care, when they don't need to have more permanent housing, and moving them from acute care into the community and having those transitional beds available for them. And remember, we did put in a request, or asked Department of Mental Health to work with VHCB to identify where the greatest needs are for mental health patients, and then working with VHCB perhaps to build some new facilities or buy new facilities. So we can circle back to that one. Go ahead.
No, I was just wondering, we got all these reports. Where is which?
That was last biennium report, and I think the work is still ongoing. But
Okay.
when we get mental health in, when we get the Department of Mental Health in, that is a question we need to ask. All these questions, and that's why I kind of brought this one up, because this is a problem. The mental health housing and support services is going to be never ending, especially with COVID, where we've seen an increase in need over the past several months. So, Katie, thank you. That is really helpful. It gets us our feet on the ground a little bit. And I do know institutions is working on that, but we want to keep an eye on it because we want to make sure that the facilities are there for the people who are in need.
And I could just add that I know in the past I've put some memos together explaining what an IMD is and how it operates in Vermont. So I'm going to take a look and see what I have that could be useful to the committee in understanding the issue.
Excellent. Thank you. We'll get that. We'll get you in to talk about that at some point. Great. Jen, I do have a question for you. This is a little different. So as you were talking about the Clinical Utilization Review Board, and then VCures, and then we also have Blueprint, and then the private health insurers also have, and ACO, they all have quality metrics and data collection. Can you talk a little bit about, again, this is not a formal report, but I thought it would be good to have a conversation around how we look at why do we have the claims database in the first place? What does the Clinical Utilization Review Board do? Help.
I will see how much I can do off the cuff.
Okay.
I had not prepared anything. So you asked first about the claims database, the all-payer claims database, which in Vermont is VCures, the Vermont Healthcare. Oh, I'm not going to get it all.
Utilization review, something. I don't know.
System, an evaluation system, something
Yes,
like that.
that's it.
That's VHCures.
Right.
And it's a place where we have all payers. It's an all-payer claims database, although after a Supreme Court case, U.S. Supreme Court case a couple years ago, we can no longer require self-funded private plans to report their utilization information. But it really it has all the information on claims, healthcare claims for services rendered in Vermont, and so allows and to Vermonters, I think, out of state as well. So it allows the Green Mountain Care Board in particular, which maintains VCures, to run reports of data, but they also allow certain data use agreements with others to allow them to use the information. And it gives us the best sense that we have of what the real utilization is of healthcare services, both in Vermont and by Vermonters. So some of that informs other work that they do, the expenditure analysis and projections for use ongoing, looking at which sectors are being used more heavily within the healthcare field than others. Also allows them even to track things, I think, like the extent to which there has or has not been an increase in certain utilization of ambulatory surgical center services or those types of services delivered at the ambulatory surgical center, now that there is a big new ambulatory surgical center online in Chittenden County, whether overall utilization has gone up, whether there's been a shift from services delivered in hospitals or other settings to that setting. So there's a lot of information available through it, but it requires certain data queries to be made. And there is a whole data team at the Green Mountain Care Board who could probably tell you a lot more about how they use that information. Is that helpful? Is that what you were looking for?
Absolutely. Yeah, no, this is very good. Because you know, some of the mysteries of what's happening in data collection are become, you know, confusing. So I think that is very helpful. The other question is around
Curb.
Is Blueprint data included within VCures?
I think to the extent it results in claims, yes, it's, you know, it's really looking at claims provided, but I do think there is some tracker that they used at least for the patients with a primary care provider who participates to the patient-centered medical homes. I do think there is a certain amount of information that they collect in VCures specifically from the Blueprint patient-centered medical homes. But again, the Green Mountain Care Board would be the best ones to ask about that. And I would expect they have somebody watching.
Well, and I think Blueprint is being moved, so we'll have a discussion about that.
Okay.
Yeah. And then I guess the other question is the private insurance utilization information that is for the self-insured. Is that collected anywhere? Does that go to a private insurer like Blue Cross and Blue Shield? Do they have their own metric?
So to the extent, and this is just by way of a little bit of background, with self-funded or self-insured employers, they, under federal law, the federal law known as ERISA, the Employee Retirement and Income Security Act, states are preempted from really doing much of anything with respect to regulation or involvement in those plans, unless they're governmental plans, which are exempt from ERISA, and therefore we can regulate. So like the state employees plan. So a lot of employers, and it used to be mostly large employers, but now some smaller employers as well, do self-fund their employee health plan, which means we don't have a lot of information about what those plans offer. They're not subject to the mandates, to Vermont's health insurance mandates, because they're not health insurance, and we cannot require those plans to cover anything in particular or do a lot of things with respect to how they run their operations. Many of those self-funded employee plans or employee health plans, the employer will contract with an insurer like Blue Cross Blue Shield or Cigna to act as the third-party administrator. So they're really kind of running the claims processing and a lot of the more insurance type activities that might be more in the specialty of, you know, in the wheelhouse of an insurer than of a business whose focus is not health insurance. So we may be able to get some information on the book of business that insurers that the state regulates has on the self-funded line. So you could ask Blue Cross and Blue Shield, and they might be able to give you some information about what they do. But you cannot require that those claims to be included in the all-payer claims database, VCures. And that is specifically the result of a case that went up to the US Supreme Court challenging Vermont's inclusion of that or requiring inclusion of that information in VCure. So it's not just a theoretical prohibition, it's pretty clear from the US Supreme Court as applied to Vermont. Liberty Mutual versus Gobay. So for those of you who recognize Al Gobay's name there, he was named as in that.
But if we were in
Sheriff
Maine or New Hampshire, they could collect the data.
It still would have to be voluntary. So it's only through voluntary.
Yeah.
I mean, the ruling itself applies more broadly than just
Okay.
Vermont because it is a US Supreme Court case, not even
That's
just a Second Circuit case.
Just have to be caught, that's all. I'm sorry.
Right, so somebody would have to complain and then it would
Right.
be,
Senator Cummings and then Senator Hooker.
Uh, when we're doing agenda planning, it might be helpful. It would be helpful for me to get on visual, a side by side, because we did healthcare reform and we failed. And we've done all these other things before, during, and after trying to move us to reform. And so we've got the blueprint, we've got all payer, we've now got Vicki Lohner's folks, we've got Green Mountain Care. How do those all mesh together? The
So this,
blueprint, I believe, was pre-reform. It's still in there along with all payer. But they all seem to use backup services or encourage them. And I think it would be helpful to just be able to figure out who all the players are at this point.
so I have a couple of responses, if I may. First is, I think we want to be careful how we use the term healthcare reform and what may have failed or not failed. I think the Act 48 vision of a universal unified healthcare system did not ultimately
Did not
advance.
pass, right.
Right. So the financing was not enacted and that particular route has not been pursued since. But I think a lot of the other things that you mentioned really are still considered to be healthcare reform. I think blueprint, all payer model, ACO, is all considered, I think, generally to be healthcare reform. It's changing it. Whether people think that's for the better or for the worse, I think is more subjective. But I think I'm hoping that when you get the overview from Ina Backus, if she hasn't already finalized what she's presenting to you and doesn't have that in it, that she would be in a good position as the director of healthcare reform in the Agency of Human Services to put those pieces together for you, to show you where the blueprint informs what they're doing with the all payer model and how the other pieces fit together. I think your question is a good one to call attention to whether there is duplication and or gaps as a result of some of these initiatives. And I think the chair has been interested in the past in alignment and making sure that that everything is working together and that there aren't either duplications of efforts or people working at cross purposes that don't complement each other.
thank you for that. I agree with everything you said. And Senator Cummings, that's exactly why we will have Ina Backus in tomorrow. And then, the purpose of my question for Jen was just to open up this whole area and to understand that what we know, what we don't know. And so if we don't get to a good place and answer all the questions that you have, we can always bring folks back in. I like the idea of looking at kind of the historical development of where we are, but of course we sometimes don't have that luxury. And I go all the way back to bringing folks in from Dartmouth, talking about medical errors, and talking about overutilization and so on. And we've started to move beyond that, but for me, as I think Jen has said, aligning some of the work that we're doing increases the efficiency in the system, but it also improves access and quality at the same time. So that's where my brain has been headed, and we'll just see what other folks are thinking about as we build our information together. Senator Hooker.
Just a question about ERISAs and the number of Vermonters that are covered under that type of program. And Jen, you said that there would be information that would be available through the third-party payer or third-party managers with regard to ERISA, and that could be included in in the data of, how much healthcare is being used?
So yes and no. So to your first question, how many Vermonters are in self-funded plans? I don't know that number off the top of my head, but it's a lot. It's more than we have in fully insured plans. So I think I'm going to get it wrong. So my recollection is somewhere in the 200,000 range, but that could be entirely wrong. So I would invite people at the Green Mountain Care Board or elsewhere to follow up with me or with the committee about what that number is, because I know I've seen it places, but part of it is that because there is no state regulation of it, we don't have a clear picture. So yes, you may be able to get some information on utilization from third-party administrators, but it would be limited to their own book of business and the self-funded plans. So I know I've heard, Sarah Teachout on behalf of Blue Cross Blue Shield talk before about some things related to their third-party administrator duties. You certainly can get information as it relates to the state employee health plan and to the plans administered through VHI for the teachers and school administrators and other school staff. But for the garden variety private business that self-funds, we don't have any ability to compel them to report anything. And so that includes, to the extent their utilization data is included in the all-payer claims database, it would be voluntary. It would be either because they felt it was important to have that information counted in when the state is reviewing utilization activities, or otherwise have chosen to voluntarily participate.
Okay, yes, this continues to be for me, an issue and a problem in terms of building and attributing lives to our current program. So, yeah.
Right. So that's a good point as well, is that, for example, the state cannot require the self-funded plans to participate in the all-payer model.
What's fascinating to me about that is how the improvement it makes for all payer payment per member per month, what an improvement it is, not just for the provider, but also for the patient. It doesn't change the benefit structure. It only increases access, and I also think prevention and quality. So the moving toward all payer, regardless of what insurance program you're under, whether it's self-insured or other, it can be extremely helpful. And I know we're moving more in the direction of primary care. We haven't stepped into the area of specialty care, but I would think that anyone who's looking at insuring their own employees would want to look at the benefit of the all-payer model. That's my opinion. So,
and the other piece that may be just important for you as senators to understand about the self-funded plans and the fact that the state does not and cannot regulate them is that sometimes you'll hear complaints from or concerns from constituents about not having something covered as they might expect under their health insurance. They may have a card that says Blue Cross or Cigna, and they expect that it would follow Vermont's benefit mandates and consumer protection provisions. And because those plans do not have to comply with Vermont's requirements and are not subject to state regulation, they may actually be on a self-funded plan that is outside of the state's regulations. So that's something to know if you're hearing about things that don't seem to fit with your understanding of what's allowed and what's not allowed under Vermont law, as they may be regulated purely under federal law.
okay, I think we've just about had sufficient for the day. Are there other questions for Jen and Katie? Listen, I want to thank you both. That's a lot of work, putting together all the reports and then walking us through. We really appreciate it. And if you can, I'm sure that I'm going to review the little categories that we have. And as we're each looking at the reports, I know that Katie and Jen may be able to help further. And if there are things that we need to bring back into committee, we can do that. So just let me know. You can let Ruth know or let me know, and that would be good, or Jen and Katie, that'd be helpful. So then on the categories that I have now, and you can correct me going forward. Cheryl, you're looking at housing, homelessness, long-term care, choices for care, long-term ombudsman, and healthcare advocate. Okay. Ruth is looking at childcare, parent-child centers, childcare providers, council, the pre-K issues. That one is going to be a big one for us coming up, but there's a number of reports there. Anne is looking at the Alzheimer's, maybe some of the older Vermonters issues, the deaf and hard of hearing, vital, which is a step away from that, but that's helpful. How's that so far? So good. And then I'm looking at a whole lot of stuff on provider stabilization, Green Mountain Care Board, and everybody's looking at Green Mountain Care Board as much as they want. Mental health, including Brattleboro Retreat, global commitment stuff. So that kind of stuff. And then we'll ask Josh to look at substance use disorder prevention and the Prevention Council for us. There are some things that are not in any category. I think, for example, Reach Up isn't right there. Hub and Spoke, that is part of the substance use disorder stuff, but we can sort of work on that together. Anything else? How does that sound? Sounds as usual, a lot mixed up. You can unmute yourselves, all of you, and if you just have something to say, just say it. We're good?
I think it sounds fine. Yeah.
Okay. All right. Remember, your goal, identifying recommendations that can come into committee as we're looking at these areas and building some policy recommendations. We
And
will
also
have
seeing whether the reports are even necessary moving forward.
that is really important. And then, maybe there's a report that we can get a one pager and the data is available in the department or agency. There's a lot of work that goes into these reports. We really want to respect the work of the people who are doing it, and I do, but we don't want to make it something that becomes busy work or annoyance. It should be meaningful. It is meaningful to us, and we want to make sure we get it all, but we don't need more than we need. Okay. Well, in the tradition of our committee, I think we finished early. If anyone has another comment, Senator Hooker.
I think Senator Hardy had a comment about wellness.
Oh, yes. Go for it.
Okay, so we were chatting before we went live on YouTube, so I'm going to repeat what I said, where we were talking about our own mental health and wellness and how sometimes we need to take breaks and get outside and spend time with family, and that may require us to, or may happen that we get behind on our email and all of our reading and all of the work that we have to do as senators and as staff members, but that we all give each other permission to take care of ourselves, and that it's really important, especially now, given everything that's going on. So just an encouragement to everybody in this meeting and everyone who may be listening to take care of yourself and to not feel bad about it. So thanks.
Oh, good. I like that. And just FYI, I did that this past weekend. So there are some emails that didn't get responded to, and but it helps us all maintain our outlook, optimism, mental health. We all need it. So thank you, Senator Hardy. And I'm going to try and think of something we can do as a regular wellness event for our committee. It's online, but we'll think of something. All right. Thank you all. Thank you, Jen and Katie, again. And we'll see you tomorrow morning at 9 o'clock. Well, we'll see you later, but here, 9 o'clock tomorrow. Take care.
Thanks, everyone. Bye.
All right. Nellie, we're good. We can leave.